Hi, I'm Andrew Miller, and I'm going to present a video abstract on high-frequency percussive ventilation and viral bronchiolitis from White and colleagues. A little bit of background. Bronchiolitis is the most common reason for PICU admission. About 5% of kids with bronchiolitis end up requiring mechanical ventilation, and they're difficult to manage. Most kids don't need advanced ventilator modes, but some do progress to severe respiratory failure and require high-frequency ventilation. This can be delivered by jet ventilation, HFOV, or high-frequency percussive ventilation, which is what this paper is about. And how they did their study is they performed a prospective observational cohort study at a single center, which was Primary Children's in Salt Lake City, Utah. Their inclusion criteria were diagnosis of viral bronchiolitis. They excluded kids that were less than 28 days to exclude perinatal lung disease, or over 24 months of age to prevent overlap with asthma and other diseases, kids with congenital heart disease, those who were only on HFPV for less than 12 hours, and those that were put on HFPV during ECMO. Then they hypothesized that HFPV would improve oxygenation. And results, so they had 192 PICU admissions with mechanical ventilation. 21% of those received HFPV. Six subjects were excluded. 2 improved and were transitioned back to conventional mechanical ventilation. 3 worsened and were placed on ECMO. And then that left a total of 35 subjects that were studied. They were a median of 4 months old. 63% were male, and they were 6.1 kilos. All the subjects met pediatric ARDS criteria. Then they were ventilated for just over a day, or 28.7 hours, before they were started on HFPV. And what their primary findings they found, CO2 decreased, but there was no change in oxygen saturation index. They found a lower PIP, mean airway pressure was higher, PEEP was higher, and importantly, 94% of the patients received neuromuscular blockade. And you can see here on this figure very clearly that there was a significant decrease in PCO2, and this was a combination of both arterial and capillary CO2. And this is just another table highlighting the same results. So you can see here the CO2 goes down significantly, and the PIP was lower, but the mean airway pressure was higher, and the PEEP was also higher. So no change in OSI, but improvement in ventilation, which could have been related to better lung recruitment from the increased mean airway pressure. Little discussion, so the ventilation improved, there was no change in oxygenation. So this is similar to some findings, recent studies on high frequency jet ventilation in bronchiolitis. It was used in a wide range of indications. Most of the kids had ARDS, and then it was pretty safe with minimal complications. The limitations of this study are the small sample size, the lack of a control group. They didn't protocolize HFPV use. They didn't measure any lung mechanics pre-HFPV. And then they didn't include the pH in the measurements of gas exchange, so we don't really know how acidotic these patients were. And then importantly, they combined the arterial and capillary CO2, which is another significant limitation. And then finally, they didn't measure the HFPV pressures with an external manometer, which is an important aspect of managing patients on HFPV. And in conclusion, HFPV improved ventilation, but did not have any impact on oxygenation. And thank you. Please subscribe to our YouTube channel. You can follow us on Twitter, Facebook, and feel free to email me with any questions.